Hello everyone. As a part of continuous cardiac education, our topic of discussion today is Conotruncal Anomalies by Dr. Keval Kanabarsar, who is Assistant Professor in the Cardiology Department at Unmicrc Hospital, having 6 years of experience in the field of interventional cardiology. Looking forward to your kind presence. Thank you.
Hello everyone. I'm Dr. Keval. I'm Assistant Professor in the Department of Cardiology at Unmicrc Institute of Cardiology and Research Center, Ahmedabad. I'll be discussing on the conotruncal anomalies. Now, conotruncal anomalies are a wide range of congenital disorders which involve either the conus or the truncus. Now, we know from the embryology that the heart basically develops from the primitive heart tube, which is divided into the primitive atria and the primitive ventricles. However, the major vessels form from these two structures, the conus and the truncus. The conus is primarily the region between the ventricle and the semilunar valves, that is the region between the RVLV and the pulmonary valve and the aortic valve. And truncus is basically a primitive embryonic portion between these semilunar valves and the great vessels. To understand the conotruncal anomalies, it is very important to understand the embryology of the conus and the truncus. So, the conotruncus is basically conus and the truncus. Conus is the segment between the ventricle and the semilunar valves, and it gives rise to both subarterial coni, that is the subaortic conus and the subpulmonary conus. Truncus is the portion between the semilunar valves and the great arteries. Now, the embryology of the conotruncus is basically divided into several stages, and to understand the different anomalies involving the conotruncal septum, it is important to understand this embryology. Now, the important steps which take place during the embryonic life is septation of the conus and the truncus, the rotation and the absorption of the coni, development of the semilunar valves, and then we will discuss the congenital heart diseases which are associated with the conotruncal septum. Now, first we discuss the septation of the conus and the truncus. Now, there are 4 truncal cushions and 2 conal cushions, right? The truncal cushions and the conal cushions will fuse to form the truncus arteriosus, which is present in the embryonic life. It will give rise to a single embryonic structure, that is the truncus arteriosus. So, the dextro-sinistro cushions of both conus and the truncus fuse to form the conotruncal septum, and the intercalated cushions, as we can see in the figure on the left, will give rise to the development of the semilunar valves. So, the intercalated cushions will form the semilunar valves, and the remaining 2 cushions from the trunci and the coni will give rise to the conotruncal septum. Now, in the septation of the conotruncal septum, now we need to understand that in the truncus, the cushions are dextro-superior and left inferior. So, they are right superior and left inferior. Whereas in the conus, these cushions are dextro-dorsal, that is right posterior, and sinistro-ventral or left anterior. And that is why the conotruncal septum which develops in the truncus arteriosus is always a spiral septum. We will see it in one of the upcoming slides that the conotruncal septum which develops is basically a spiral septum. So, some people also call this conotruncal septum as the spiral septum. So, within the truncus arteriosus, a spiral septum develops which separates the pulmonary artery from the aorta. So, in the figure which we see on the right, on the left side of the figure is the left ventricle, on the right side of the figure is the right ventricle. The left ventricle gets connected to the aorta and the right ventricle gets connected to the pulmonary artery because of the development of this spiral septum. Next, in the embryology is the rotation and the absorption. So, aorta in the early embryonic life, since it is a right-sided structure, will be in connection with the right ventricle, and pulmonary artery being a left-sided structure will be in connection with the left ventricle. 2 rotations take place, one at the conoventricular junction and another at the conotruncal junction. Both of these are around 110 degrees and both of these rotations are counterclockwise. This conoventricular rotation brings aorta in continuation with the LV and PA with the RV. And the conotruncal rotation brings the normal position of aorta in relation to the pulmonary artery. It brings the aorta to the right and posterior to the pulmonary artery, right? So, the normal position of the aorta is right and posterior to the pulmonary artery. So, the conoventricular rotation is going to align the ventricle with the respective great chambers, and the conotruncal rotation is going to result in the normal position of the aorta in respect to the pulmonary artery. Second most important thing is the absorption of the conus. Out of the 2 coni which ever remain persistent and grow, it pushes the artery more anterior and superior, bringing it in direct connection with the right ventricle. So, in the embryonic life, we have a subaortic conus and the subpulmonary conus. In the normal conditions, the subaortic conus gets resolved. It gets resolved. So, there is a fibrous continuity between the aortic valve and the mitral valve, whereas the subpulmonic conus usually persists. And as we have seen, the intercalated cushions will give rise to the formation of the aortic valve and the pulmonary valve, right? The intercalated cushions from the truncal septum will give rise to these 2 valves. So let us see this video. Here we see the truncus arteriosus. So truncus arteriosus is a common chamber which will give rise to the future pulmonary arteries in the aorta. Now this is just an animation to show how the septum, the spiral septum or the conotruncal septum develops. So truncus arteriosus initially, which is a single structure, is going to ultimately give rise to the two great vessels of the heart, that is aorta and the pulmonary artery. In the top above we see the atrium and below we see the ventricle. Here we see labeled two structures, aorta and the pulmonary artery. They are not in their respective positions right now because this is early embryonic life. So here we can see that a spiral septum is developing. This is because of the fusion of the conal septum with the truncal septum, right? And this spiral septum is ultimately going to merge with the ventricular septum below, and the conoventricular portion of the ventricular septum ultimately gets filled, and this results in completion of the embryonic ventricle. So this separates the right ventricle from the left ventricle, and this connects the respective ventricles with their great vessels. So this is an oblique view. Then we will next see an AP view. So here we see that there is the left ventricle and the right ventricle, and we see that there is the truncus arteriosus, the aorticopulmonary septum or the conotruncal septum is now forming, and it is ultimately resulting in development of a spiral septum which fuses with the ventricular septum below, and it connects the aorta with the left ventricle and the pulmonary artery with the right ventricle. So we can see that the left ventricular blood now drains into the aorta, which is a right and posterior structure, and the blood from the right ventricle enters into the pulmonary artery, which is an anterior structure and a leftward structure. So the normal position of the pulmonary artery is left and anterior, and the aorta is right and posterior. Now, the abnormalities of the conotruncal septum are several, which are very important for us are truncus arteriosus, tetralogy of Fallot, DORV and TGA, right? We'll discuss these in detail. There are some syndromes associated with these conotruncal anomalies. The most important of these are trisomy 13 and trisomy 18, which are both associated with TOF, DORV and conoventricular VSDs. Trisomy 21 or Down syndrome is associated with tetralogy. Deletion 22q11 is associated with truncus arteriosus, and the DiGeorge sequence is associated with interrupted aortic arch. Velocardiofacial syndrome is associated with TOF with pulmonary atresia, DORV and conoventricular VSDs. Some autosomal dominant conditions like Ehlers-Danlos syndrome, CHARGE syndrome, and some autosomal recessive conditions like TAR syndrome or thrombocytopenia with absent radius syndrome are also associated with conotruncal anomalies. But the important ones are trisomy 13, trisomy 18, trisomy 21 and deletion 22q11, particularly DiGeorge syndrome, which is associated with interrupted aortic arch type B. Now let us discuss the first conotruncal anomaly, that is the truncus arteriosus. Now truncus arteriosus primarily develops because of the failure of the septation of the aorticopulmonary septum or the conotruncal septum. So if this conotruncal septum or the spiral septum or the aorticopulmonary septum does not develop, then it results in an embryonic condition which something very similar to what was present in the intrauterine life, early intrauterine life, that is there is a single large vessel, and this single large vessel is called as the truncus arteriosus. It accounts for 0.7% of all congenital heart diseases and accounts for around 4% of all critical CHDs. The truncus arteriosus is classified as per several classifications like Collett and Edwards classification, Van Praag's classification. What is the most commonly used classification is Collett and Edwards classification, right? It has been shown that cigarette consumption is associated with increased risks of truncus arteriosus, and conotruncal anomalies including truncus are associated with 22q11 deletions, right? Deletions in certain genes like TBX1, CRKL and ERK2 are associated with development of truncus arteriosus. Now this is the classification, the Collett and Edwards classification in the figure on the left. Collett and Edwards classification type 1 is basically when there are two separate great vessels. One is the aorta and there is the main pulmonary artery. Main pulmonary artery is dividing into right and left pulmonary arteries. Type 2 is when the right and left pulmonary arteries arise separately and posteriorly from the aorta. Type 3 is when the right and left pulmonary arteries arise from aorta, but they arise from the lateral aspects of the aorta. Right. Type 4 is some people no longer consider it as a part of truncus arteriosus, and here when it's basically a type of VSD with pulmonary atresia. The physiology is that it is basically an admixture physiology. There are several diseases which come in admixture physiology, like common atrium, totally anomalous pulmonary venous return, truncus arteriosus. So truncus arteriosus is one form of an admixture physiology where the admixture is taking place at the great arterial level, and that is why patients are usually not deeply cynosed. There is some moderate amount of cyanosis, but with the progressive fall in pulmonary vascular resistance at around 4 weeks after birth, pulmonary blood flow is going to increase and patients will usually come to us with congestive cardiac failure. So congestive cardiac failure with cyanosis usually presenting at 4 to 6 weeks of life goes in favor of truncus arteriosus. Right? Some patients may have truncal valve regurgitation, they may have increased risks of coronary artery ischemia and ventricular dysfunction. Most patients present within the first weeks, mainly with respiratory distress due to pulmonary congestion and heart failure. There are very few survivors, natural survivors of truncus arteriosus. Most of these patients unoperated will die by 1 year of age, and if not, they are ultimately convert into Eisenmenger syndrome. Echocardiography will usually provide us the diagnosis of truncus arteriosus, and we can see in parasternal long axis view or in the apical 5-chamber view that there is a single great vessel arising from both the ventricles, and it ultimately divides into aorta and the pulmonary arteries, and depending upon the pulmonary artery anatomy, we can classify it as per the Collett and Edwards classification. The medical management usually consists of inotropes if there is ventricular dysfunction, diuretics. The treatment of choice is primary repair should be done as early as possible. Here we are basically going to mobilize the pulmonary arteries, and we are going to put an RV to PA conduit. We'll repair the VSD and we'll open the truncus, and we use a homograft or a pericardial patch to repair the truncus. Truncus arteriosus as such is a relatively rare condition. What is very common and one of the most common congenital heart diseases, in fact one of the most common cyanotic congenital heart diseases, especially in adults, is tetralogy. So tetralogy of Fallot is the prevalence is 4 to 5 per 10,000, accounts for almost 10% cases of congenital heart disease, and one of the most common conditions requiring intervention in the first year of life. There is no sex predilection for this condition. It basically has 4 components. There is usually a large non-restrictive VSD, usually with bidirectional shunting. There is severe right ventricular outflow tract obstruction, that is infundibular and valvular pulmonary stenosis. There is overriding of the aorta, and consequent to the RVOTO, there is right ventricular hypertrophy. A 5th component in pentology of Fallot is when they have a tetralogy with an ASD. Now, TOF with a pulmonary valve atresia and and MAPCAS is the most extreme variant of TOF. So TOF with pulmonary atresia is a very severe condition, and it's one of the extreme forms. Another condition is TOF with absent pulmonary valve, which presents with pulmonary stenosis and pulmonary regurgitation. Now we have to understand the normal anatomy of the great vessels. Normally the aorta is posterior and the pulmonary artery is anterior. Think of it as my right hand is anterior and my left hand is posterior, right? So in the embryonic life, consider that the pulmonary artery is anterior and the aorta is posterior. If the spiral septum develops in such a way that there is anterior displacement of the aorta or anterior displacement of the conoventricular septum, we can realize that this aorta is going to be large, what is posterior is going to be large, and there will be stenosis of what is the anterior structure, that is the pulmonary artery. So tetralogy of Fallot is basically because of anterior and cephalic deviation of the conotruncal septum. Cephalic displacement is not very important. What is more important is anterior displacement. So there is anterior displacement of the aorticopulmonary septum or the conal septum, which results in a large VSD. So we usually have a large non-restrictive VSD, and consequent to the anterior displacement, there will be narrowing of the pulmonary artery. So maybe the narrowing of the RVOT or the pulmonary valve or the pulmonary artery. All of these will result in severe pulmonary stenosis and also result in right ventricular hypertrophy. And because of the anterior displacement of the septum, we are also going to have an aortic override. So that is, aorta will usually have a biventricular region from the left ventricle as well as a part of it from the right ventricle. Associated cardiac anomalies are frequently seen in TOF, including right-sided aortic arch, or these patients may have additional ASDs, additional muscular VSDs, coronary artery anomalies, right? Coronary artery anomalies, particularly LAD from RCA, is seen in around 10% of patients. Some patients may have a large conal branch crossing the RVOT. Patients may have additional MAPCAs which may need to be addressed prior to surgery. Patients can have PDAs, VSDs, complete AV canal defects. Some patients may have aortic regurgitation. Now, the pathophysiology depends primarily on one condition, that is the severity of RVOTO. VSD is typically large, it is non-restrictive, it is going to shunt bidirectionally. The degree of pulmonary stenosis is going to decide your severity. If the pulmonary stenosis is mild, these patients are typically going to have pink TOF, that is, these patients are not going to have cyanosis. But if it is severe, then patients are usually cyanosed, and saturation fluctuates in the range of 60 to 80 or 90%. Cyanotic spells are a very characteristic feature of tetralogy, usually seen between 3 months to 2 years of age. Exact etiology is not known. Some theories say that it may be because of infundibular hypercontractility, maybe because of peripheral vasodilatation, hyperventilation, stimulation of right ventricular mechanoreceptors, right? So, whatever the precipitating etiology, the vicious cycle of tetralogy of Fillet is the same. Maybe it is because of spasm of the RVOT, maybe because of crying, maybe because of hyperventilation, or because of decreased systemic vascular resistance. All of these conditions are going to result in increase in the right to left shunt. If your SVR goes down, or if you are hyperventilating, your right to left shunt is going to increase. Once your right to left shunt increases, deoxygenated blood from the right ventricle will enter into the left ventricle, aorta, systemic circulation, and that is why these patients are going to have acidosis, increased CO2, decreased bicarbonate, decreased pH. And to compensate for this systemic acidosis, the patient will further hyperventilate, they will have hyperpnea. Once they have hyperpnea, their systemic venous return will increase. Once systemic venous return increases, it will again increase the left to right shunt, further increasing acidosis and hyperpnea. So this is basically a vicious cycle. Anything that increases the right to left shunt is going to cause systemic acidosis and hypoxemia, which will cause hyperpnea and increase systemic venous return. And to break this cycle, we can act at several points. One, we can either relieve the spasm of the RVOT by giving beta blockers. We can reduce the crying. We can give IV fluids to counteract the acidosis, or we can increase the systemic vascular resistance. Right? The clinical presentation of this condition, children with severe obstruction and decreased QP typically present in the immediate newborn period with profound cyanosis. Children with moderate obstruction may be noticed electively when they are being examined by a pediatrician. Typically, patients present with cyanotic episodes at around 3 to 6 months of age, may persist till 2 years of age, and if undetected and undiagnosed, they can also be diagnosed during early childhood or during early adult life. As I said, cyanotic spells are a typical feature of tetralogy. Some newborns may be detected because of a field oximetry test, but most of the times, even in severe tetralogy, the saturation is normal during the early early newborn period, particularly during the first 7 days of life. On inspection, they are usually comfortable. First heart sound is normal, the second heart sound is single. Sometimes there may be an early systolic click, but most of the times we do not hear it. The murmur is primarily because of the right ventricular outflow tract obstruction. The more severe the stenosis, the lower the intensity of the murmur, right? The more severe the stenosis, the lower the pulmonary blood flow and lower the intensity of the murmur. Unlike in patients with severe PS without a VSD, where the intensity of the murmur correlates with the severity of the stenosis. In TOF, severe the stenosis, lower the murmur. And that is why patients who are in spells have absence of murmur. The diagnosis is usually made on the basis of clinical examination and echocardiography. Echocardiography is going to give us vital information like the size of the VSD, the degree of aortic override, the degree of pulmonary stenosis, most importantly the size of the pulmonary arteries and the aortic arterial, the coronary artery anatomy. It is also going to give us any associated anomalies which need to be repaired during surgery, like ASDs, PDAs, additional VSDs, right? The degree of the aortic override is best seen in the parasternal long axis view. Here we can see in a parasternal long axis view that aorta has a biventricular origin. It primarily originates from the left ventricle and partly from the right ventricle because of the anterior displacement of the aorta. And the degree of aortic override here, it is around 40% of aortic override. It's best estimated on a parasternal long axis view. Also, apical 5 chamber view can give us an idea about the aortic override. The extension of the defect from the membranous septum beneath the tricuspid valve and into the infracrustal outlet septum is also well seen in the parasternal short axis view, right? And if there is an extension of the VSD towards the inlet septum, it can be seen in the apical view. Right, in a parasternal short axis view, we are going to get an idea about the size of the VSD, the bidirectional shunt, we can also see the pulmonary arteries. Here we are not able to see the pulmonary artery in this figure, but otherwise we can also see the pulmonary arteries in the bifurcation of the main pulmonary artery. The multiple levels and severity of obstruction of the RVOTO can be evaluated on a parasternal short axis view, also in the subcostal view. The pulmonary arteries, as I said, is best assessed in the parasternal short axis view, and pulmonary arteries are also well seen in a suprasternal view. The proximal coronary arteries are again well seen on parasternal short axis view and should always be defined, particularly if there is a coronary artery which is crossing the RVOT. In that case, the surgical plan needs to be changed, and patients may need to go for an initial shunt followed by a definitive surgery at around 3 to 4 years of age. Now, management of tetralogy is very important. So the management of spells is basically by giving them, by calming them down. You can give them positions like knee squat, you can put them in a squatting position or a knee chest position. We give them beta blockers, particularly propranolol, which helps reduce the RVOT spasm. We give fluids and bicarbonate to counteract the hypoxemia and acidosis, and then we can give systemic vasopressors in order to maintain the systemic vascular resistance. Antibiotic prophylaxis for any dental procedure or GI procedure is indicated because this is a cyanotic congenital heart disease. The surgical management is either palliative or corrective. Palliative shunts like a modified BT shunt or POTS shunt or ascending aorta to PA shunts are required in when they present very early in life, particularly less than 3 months of age, and in certain centers less than 6 months of age. So the guidelines say that TOP should usually be repaired by 6 months of age, around 6 months of age, but it depends upon institutional practice. So in Western countries, as early as 3 to 6 months of age, a corrective surgery may be done, but in most centers in India, the corrective surgery is being done at around 6 to 12 months of age. In the center where I work, corrective surgery is usually done at around 6 months of age, and if somebody comes before that with severe cyanosis, recurrent spells, not managed medically, then these patients need to go for a palliative shunting, particularly the modified BT shunt, right, where we put a Gore-Tex interposition graft between the pulmonary artery and the aorta opposite to the side of the arch. So if we have a left-sided aortic arch, which is the routine which is more common, we are going to put a modified BT shunt on the right side, connecting the right pulmonary artery with the right subclavian artery, right. Definitive repair timing I have already discussed. At around 6 months of age is routine in our country, maybe at a lower age in Western countries. Perioperative complications, there are several: pericardial effusion, persistent RVOT obstruction, residual VSD, electrical abnormalities like right bundle branch block, bifascicular blocks, complete heart blocks, pulmonary regurgitation at follow-up are very common complications. Perioperative mortality varies from center to center, and the worldwide mortality for intracardiac repair for tetralogy of fillet ranges somewhere between 0.5 to 1%. Management of adults with tetralogy is complicated. These patients may have additional MAPCAs or multiple aortopulmonary collaterals which need to be addressed before surgery. These patients also may have additional abnormalities like ventricular dysfunction which need to be addressed, or aortic valve regurgitation. So these need to be managed in adults. In adults, always we need to look at the pulmonary arteries because the echocardiographic window is not that great in adults, and these patients may need to undergo imaging of the pulmonary artery in the form of either a CT pulmonary angio, or they may also need a conventional CAT study to assess the size of the pulmonary arteries and assess the McGoon's ratio and other ratios which decide whether the patient is a candidate for intracardiac repair. Next we discuss in tetralogy of fillet, as I said, intracardiac repair preferably done at 6 months of age is a treatment of choice. But if a patient comes later, all these patients need to undergo surgery. At any age, if tetralogy of fillet is detected even later in life, these need to be treated with an intracardiac repair. Right? In the intracardiac repair, we are basically going to close off the VSD. We are going to resect the infundibular stenosis. We are going to manage this stenosis. Maybe sometimes we put a pericardial patch in order to resolve the stenosis, and we are basically going to close the VSD and treat the pulmonary stenosis, right. In patients who have abnormal coronary arteries which cross the RVOT, they need to be treated with a conduit, right. And if you need to put a conduit, you cannot put a conduit in a 6-month-old baby. So to put a conduit, RV to be a conduit, we need to wait till around 3 to 4 years of age. So these patients who have abnormal coronaries which cross the RVOT, they need to be managed with a palliative Blalock-Taussig shunt and then undergo surgery at around 3 to 4 months of age. Another option is when the pulmonary annulus is small, the main pulmonary artery is small, then we can put a patch patch which will help in the surgery, right? Next abnormality which we are going to discuss is the DTGA, or the transposition of great arteries. The transposition of great arteries, DTG, occurs primarily because of the absence of the conoventricular rotation, right? There is no conoventricular rotation which is taking place, the rotation between the conal septum and the ventricular septum, and there is persistence of both coni. So there is the persistence of it's because of persistence of the subaortic conus with a complete resorption of the subpulmonic conus. So subaortic conus over here is going to persist, and that is why there will be no continuity between the mitral valve and the aortic valve, whereas the subpulmonic conus resolves. The prevalence of TGA is around 4.7 per 10,000, and it accounts for 3% of all CHDs and around 20% of all cyanotic congenital heart diseases. Simple DTGA is without any other cardiac defect, and complex DTGA is those with an additional cardiac lesion. So normally we have two coni, the subaortic conus gets resorbed and the subpulmonic conus persists, right? Because of the resorption of the subaortic conus at around 30 to 34 days of gestation, the aortic valve moves inferiorly and posteriorly, and it comes in direct continuity with the left ventricle. The resorption of the subaortic conus results in the complete fibrous continuity between the mitral and the aortic valve. The pulmonary valve retains its association with the right ventricle due to persistence of the subpulmonic conus. Now, in TGA, we have seen that the subaortic conus persists and the subpulmonic conus gets resorbed. Additionally, these patients have VSDs. 50% of patients with TGA have VSDs, and it can be found anywhere. It can be a muscular VSD, membranous VSD, inlet VSD, or perimembranous VSD. Patients with VSDs will be those who have complex TDGAs, and they may have additional pulmonary stenosis or atresia. Now, left ventricular outflow tract obstruction. So, left ventricle is now connected with the pulmonary artery, right? So, LVOTO basically means that there is pulmonary stenosis. It occurs in 25% of the patients. In patients with an intact septum, the systemic right ventricular pressure causes the interventricular septum to move towards the left ventricle, causing dynamic obstruction between mitral valve and the septum. Patients with VSDs are more likely to have anatomical LVOTOs, right? So, patients who have VSDs are more likely to have severe pulmonary stenosis. This subset of patients have also a higher incidence of aortic arch obstruction, including an interrupted aortic arch. Now, in TGA, the usual connection is the left atrium. It goes to the left ventricle. Left ventricle is connected to the pulmonary artery, right? And the right atrium is connected to the right ventricle. Right ventricle is connected to the aorta. So, rather than the circulation being in series, this circulation is in parallel. The systemic blood flow comes from IVC, SVC into RA-RV and then goes into the aorta. The pulmonary circulation comes from the LA-LV and then goes into the pulmonary artery. So, at some level there has to be a mixing between the systemic circulation and the pulmonary circulation. Now, this level can be any. It could be an ASD, it could be a VSD, it could be a PDA, right? If it's a VSD or a PDA, it provides a good admixture between the systemic and the pulmonary circulation. But if the ventricular septum is intact and PDA is absent, then the only connection between these two is an atrium. And atrial septum, if there is a small ASD, then these patients are going to be intensely cyanotic. So, some form of connection is required in these patients, and if it is not present, these patients usually after birth will come with systemic cyanosis, severe cyanosis, and these patients will also have circulatory collapse, and these need to be managed early with a prostaglandin infusion. And patients who come with an intact septum, they also may need to undergo early palliative surgery in the form of BAS or balloon atrial septostomy. So, in the coronary artery anomalies in DTGA, coronaries usually come from sinuses of Valsalva that face the pulmonary artery. They come from the facing sinus. So, in 2/3 of the patients, left coronary artery arises from the left facing sinus, because that is what is going to face the pulmonary artery, and the RCA comes from the right sinus and the posteriorly facing sinus. And TGA usually presents in the neonatal period. Degree of cyanosis, as I mentioned, is determined by the amount of circulatory mixing, depends on the presence of ASD. A VSD usually will result in good mixing, less cyanosis, but more of pulmonary blood flow and more of pulmonary overload and heart failure. Infants with mild cyanosis may lack other apparent signs, and the lesion may only be detected on the basis of a failed oximetry test. As compared to TOF, which is affected by crying or feeding, cyanosis is not affected by exertion or the use of supplemental oxygen. Neonates with intact IVS are going to be severely cyanotic, and the severity is modified by the presence of an ASD or a PDM. Patients with intact IVS are at the highest risk, and this is one of the worst substrates. Natural course, if not operated, most of these will die in first year of life, and mortality at 1 year is around 90%. Diagnosis is made on the basis of an echo, which is going to give us almost all the details. X-ray is going to show us an egg on a string appearance, right? And CAT study sometimes may be needed for diagnosis of TGA, right? So this is an egg on string appearance typically seen in TGA. So if on a fetal echo we made the diagnosis, then institutional delivery is preferred, particularly when where there are facilities available for emergency cardiac surgeries. Therapy is directed towards providing sufficient mixing between the systemic circulation and the pulmonary circulation. Prostaglandin or porcine infusion is required in patients who have ductus dependent circulation. And if patients have intact septum, small ASD, then a balloon atrial septostomy is required early in life. The definitive treatment is indicated in almost all patients, and ideally these patients should be operated in the neonatal period before 4 weeks of age, because after 4 weeks of age the left ventricle starts becoming regressed, because left ventricle is now connected to the pulmonary artery. Pulmonary artery pressures are low, left ventricle does not have to do much of work, and that is why left ventricle starts regressing. On the other hand, the right ventricle, which is connected to the aorta, is bearing all the systemic pressure and it starts getting hypertrophied. So early surgery is indicated in all other patients. In patients who have severe hypoxemia, intact IVS, small ASD, when facilities are not available for emergency surgery, we may need to subject these patients to balloon atrial septostomy. Surgical repair is a class 1 indication. In patients with simple TGA, always prefer arterial switch. Jetin's arterial switch, ASO is the preferred surgery. The second option is you can do an atrial switch. Atrial switch is basically a Senning or a mustard, right? So in arterial switch, we are going to switch the two arteries. Aorta is now going to be connected to the left ventricle and the RV is going to be connected to the pulmonary artery. The coronary cushions also need to be transferred from the respective great vessels to the new aorta. So the coronary arteries which are present in the pulmonary artery which were present in the previous aorta now need to be switched. Now the coronary buttons need to be switched to the neo aorta. Right? In patients who have TGA, VSD and PS, these groups of patients may not be able to be managed with arterial switch, because if you do just an arterial switch, then you are going to convert the pulmonary stenosis into aortic stenosis. If you just perform an arterial switch, you are going to convert pulmonary stenosis into aortic stenosis. So here we need to do a Rastelli. In Rastelli, we are going to do RV to PA conduit. We are going to close off the VSD. We are basically going to baffle the VSD. So we are going to establish a communication between RV and so we are basically going to route the VSD. We call it as routing of the VSD. We are going to route the VSD and connect the left ventricle with the aorta, and we are going to put a RV to PA conduit. Complications of arterial switch are pulmonary artery stenosis, coronary artery insufficiency, neo-aortic root dilatation and neo-aortic regurgitation. The complications of atrial switch are basically right heart failure, and these patients also are prone to develop atrial arrhythmias. Long-term follow-up of patients who have undergone either an arterial switch or an atrial switch is necessary, and particularly we need to look for neo-aortic regurgitation. We are going to look for pulmonary stenosis. We are going to look for coronary artery insufficiency. We also need to look at baffle-related complications if they have undergone an atrial switch. We want to look at the right ventricular function arrhythmias and particularly development of baffle-related complications. Long-term follow-up, as I mentioned, is necessary for patients who have undergone either of these procedures. Another condition which I have not discussed over here, which is a little more complex, is DORV, double outlet right ventricle. Double outlet right ventricle is again because of persistence of the subaortic conus when the subpulmonic conus gets resolved. It is of several types. It can be a DORV with a TOF type, which is very similar to TOF, and the only difference is that there is a persistence of the subaortic conus. It can be it could just be a large VSD with Eisenmenger syndrome. So it could be DORV with Eisenmenger syndrome, DORV severe PH. Another type is the Taussig-Bing anomaly, where we are going to have a subpulmonic VSD. These groups of patients behave very similar to TGA, and they are also known as a TGA-like physiology. The management of this again is a little complex. It will depend upon the PA pressures. It will depend upon the size of the VSD, associated pulmonary stenosis. But what was very important, that is what I have discussed: tetralogy, truncus arteriosus and TGA. Thank you.